And now we come to the next speaker. I'm very pleased to, introduce Dr. Tanvi Haldipurkar. I have seen her blossom into a fine phaco surgeon in the last 10 years. And today she's going to touch on a very important topic. In fact, it's a time when in the world, the EDOF lens is sitting to practically replace monofocal as the default lens. Now when you have this and every player comes into the market with their own EDOF, it's time we understood what this EDOF concept is and what is it that we should be looking for in EDOF. Here to you, Dr. Tanvi.
Thank you. Good afternoon, everyone. To begin with, I have no financial interest in any of the lenses I'll be mentioning today. I want to discuss few updates that we've looked at the EDOF lenses in the past, but I think that begs the question that what really is the definition of an EDOF? What is it? So the American National Standards Institute has defined an EDOF to have a depth of focus which should be 0.5 diopters more than what a monofocal lens gives. It also says that the distance corrected intermediate vision should be 20 by 30 or better in at least 50% of eyes. So it needs to be superior to a monofocal. The corrected distance visual acuity should not be less than a monofocal. And they have not mentioned any criteria for any photic phenomenon. Now we know that EDOF lenses have become a part of the presbyopia correcting armamentarium today because the transition of the distance as well as the intermediate vision is fairly good and most patients are happy without any dysphotopsia. So rather than having multiple foci like how we see in a multifocal lens, what we see with these EDOF or what we actually need today is to have a smooth non-interrupted plane of focus. Now, although the concept of EDOF has been in the market for the last 8-9 years, they've not really picked up, and that's because I think they've been marketed wrongly initially at least. For example, when Symphony came, it told us that it's going to give us vision very well at all distances and it should lack photic phenomenon. And what happened is that it lacked or rather it failed in both counts. Now today when we look at Symphony, we know that it wasn't supposed to give us good near vision but a very good distance and intermediate. So I think a better understanding of the EDOF concept, the optics will help us choose and counsel the patients better. Now we have very different EDOF lenses in the market and all of them use different principles, but these are the main 5 types that most lenses go by. So a better understanding, I think I want to classify the EDOF lenses as a pure EDOF lens which uses properties of spherical aberration, chromatic aberration, pinhole effect and the wavefront shaping. And then we have the hybrid EDOF lenses which will use optics of diffractive, refractive rings to use or add another focus with a low near power and therefore give us a good intermediate vision. I'll be discussing all these principles in brief so we can understand them better. Now spherical aberrations already exist in the eye and I think it was probably nature's way of prolonging presbyopia. But there was a time when we wanted to neutralize them to get crisp distance vision. Now we have understood how to use this spherical aberration to do our bidding and to give us a better depth of focus. But there is a limit to what we can increase and how much can we increase. A lot of studies have been done and they have shown that if we increase the spherical aberration of more than 0.6 microns, we can have, rather if we increase it more than 0.6, we would have less than 0.6, we would have a decent depth of focus without causing much blur. So therefore, armed with this knowledge, several companies are now trying to use this spherical aberration. How it actually works is very interesting and I would like to show you how. So we know this is the Zernike's pyramid. This is just for us to understand why the Z has those 2 numbers. The M denotes the number of the affected meridian and the letter N denotes the number of slopes along the meridian. Now a wavefront is flat. If it is flat, there are no aberrations. If the wavefront is affected in 2 meridians and with 2 slopes, it is called astigmatism. If it is affected in 1 meridian but has 3 slopes, it is called a coma, and this goes on so forth. When we look at spherical aberrations, which is what Dr. Vikar sir has made it easier for me to understand, is that the number of slopes that are present will lead to the type of spherical aberration that is there, and as the slopes keep increasing, it becomes more and more complex, but it gives us a larger depth of focus. Now let's see how. So if the marginal ray is the same going through the same plane as the peripheral ray, it's going to give you zero spherical aberration. The wavefront is going to be flat. But if the central or the marginal rays are flatter than the peripheral rays, it's going to increase the depth of focus. So this kind of modulation of, this is the primary spherical aberration that most lenses are employing now. Now over here, what is interesting is the first lens that I'll be discussing, which is the Rayner lens. Now this principle is used by that, where they use this additive effect of a positive spherical aberration along with the naturally existing corneal spherical aberration. So this will give us a good depth of focus and giving you a decent intermediate vision. Now scientists wanted to further stretch this optical property of the spherical aberration and see if the depth of focus can be elongated. Now this was primary spherical Z4 aberration, and when you increased another slope to it, so therefore you got a Z6, what you found that the depth of focus increased. Now you could increase these slopes either positively or negatively, and what they looked at and saw that this was larger when both the curves were positive. So an optical bench study which was conducted by Bernard et al., they found that although it made sense that both positives increased the depth of focus largely, the combination of a Z4, Z6 in the opposite directions gave the largest depth of focus. Now this principle is used by the mini well lens, which has a positive and a negative Z4 spherical aberration in alternating rings, and that's what gives you the depth of focus and good intermediate vision, while the Lux Smart lenses uses the Z4 and Z6 spherical aberration. Now although all these depth of focus in these lenses are larger, what we found is that the combination of using these higher order aberration gives you a little loss in contrast, and in case of a smaller pupil it may really not work well. So a good selection is required. Now some lenses use a pinhole principle where it reduced the parallel visual rays, thereby eliminating the refractive error and even the aberrations. But the drawback here is that it caused those visual field restrictions. But I think it may have a role in certain patients of post-RK where it could in fact improve the visual quality, but this principle of EDOFs is not really so popular anymore. Then came the lenses which made changes in the central geometry and the optics of the lens. So some changed the power from the center to the periphery, some had asymmetric power distributions, and some lenses also manipulated the wavefront by adding some kind of segment, all of which ultimately leading to a good intermediate and distance. So here you can see the optical principles of all the different lenses. Some of them are stretching the wavefront, which has a delayed and an advanced wavefront, like for example in a Vivity lens. In the ICRL cert you have different segments. They are kind of like refractive rings which help you again stretch the depth of focus. And then the magnificent, which there is an increase from the center to the periphery, which is also similar in an eye-hands lens. Then came the hybrid multifocal EDOF lenses. These are lenses which have either a refractive or a diffractive rings, and in fact they are multifocals with just a low near rad. So they give very similar defocus curves like an EDOF lens, but they will have photic phenomenons like glare halos, like how you'd expect in a multifocal. And these are the lenses which have both refractive and diffractive elements to enhance the depth of focus. So with so many IOLs to choose, it is a good idea to look at things a little bit more systematically. So this is the IOL algorithm we follow in our practice. When the cataract has been looked at primarily by an optometrist, before he is dilated or put any drops, he undergoes a biometry. The biometry will give you a basic assessment of what the corneal astigmatism is, but we go ahead and do a corneal tomography because we get a lot of data from this machine. First, it will tell me if the corneal cylinder is matching with the optical biometry. It will tell me whether it is regular, whether it has any uneven or irregular steepenings present. It gives me a clue about the posterior corneal astigmatism as well. The next very important measure, that is the pupil size, we can get even from another machine, but this could give you an understanding of which lens would you deviate towards while you use for that patient. An assessment of the angle kappa as well as angle alpha is given by the tomographer. And again, when we do the calculation, depending on what the astigmatism is, as how sir had explained, we then go with the Barrett calculator and plan it. What we also get from these tomographers, and something we shouldn't ignore nowadays, is to look at the higher order aberrations. We know that most premium lenses or any lens which may have rings in it will not work very well if the higher order aberrations are higher than 0.3. So you need to look at that. But today with the lenses And most of these lenses utilizing or manipulating the spherical aberrations, you should also look at the corneal spherical aberration profile. And this could help you understand that if you use a lens which just enhances the pre-existing corneal spherical aberration, you may do very well with a basic lens or a lens which you may not even consider if you won't look at the corneas. After all of this, we finally then dilate and do the clinical examination. So to kind of summarize with these few pointers, I want to say that if you have a cornea with spherical aberration pre-existing of around 0.2 or 0.3, a lens like a Ray 1 or a mini well will work well. If the pupils are too small, I would suggest avoiding any of these spherical aberration modifying lenses. You could even avoid Vivity, considering it has that smaller segment right in the center. And for patients who drive, you might want to avoid the hybrid EDOFs because it's going to give them those photic phenomenons in the night. And patient, if he's okay with a small near rad, most of our EDOFs today work very well. If you counsel them well, and or if you even combine them with a slight monovision, you're going to give them a very good, decent, practical visual acuity. So I would say EDOF lenses today are suitable for all ages. They give very good quality of vision with very minimal loss of contrast sensitivity. You need to look for these patients. If somebody is a poor reader, if they are having less inclusion, or rather they're not a very finicky person about their daily routines, they have active lifestyles and want good vision for distance and intermediate, then EDOF is the way to go. Well, of course, this doesn't say that we cannot do or we can do away with the trifocals, because somebody who is very hell-bent on not using glasses for reading and still wants very crisp near vision, trifocals are the lens for that. So I would say no one size fits all. At the end, EDOF is an excellent solution for presbyopia correction, and today it is a no-brainer to use an EDOF instead of a monofocal in every patient. But it will replace it, or it will replace a trifocal, or it will give a complete spectacle independence, depends on the expectation and the lifestyle of the patient, and that's where the chair time matters. So for example, a housewife who is a poor reader and will practically be spectacle free post an extended depth of focus lens, but a jeweler who may want to see things up close and still doesn't want to wear glasses will require a trifocal. So at the end, a proper counseling or using the monovision with an EDOF, I would say that the lenses are definitely here to stay and grow. Thank you very much.
Thank you, Tanvi. That was a very comprehensive talk. Finally, uh, how sensitive are you to macula which is not absolutely healthy when it comes to choosing EDOF?
So there are another subset of lenses which are called the advanced monofocal lenses today. So if the macula is not very good, I would want to stay away from the hybrid EDOFs completely. But the EDOFs which are not using the spherical aberrations but have sort of a, maybe I will choose the category which has the lens which goes from the center to periphery where there's a uniform increase, that is the lens I would probably choose. But then going for a monovision with a monofocal lens would be the best solution in a compromised macula.
Thank you so much. Now we go to the next player. Oh yeah, please.
Hello, ma'am.
Hi.
Ma'am, as you told that we have to investigate before choosing a proper EDOF lens, but in your practice, what is the maximum percentage of lens you are putting?
EDOF lenses, you mean?
Because like we don't have corneal topography or tomography.
Yeah.
So what is the most apt lens for Indian population?
So clinically, to be very honest, we are now almost shifted 80 to 90% for patients, unless it's a financial reason for them not to go for a monofocal, we do implant an EDOF lens. So I would stay away from any of the spherical aberrating modulating lenses, because you don't have a tomographer, you don't really know how will it show clinically post surgery. Lenses like the iHands, the Magnificent, the Vivity, I think, of course, the pupil needs to be looked at for Vivity, but the Magnificent lens works very well in almost every type of subset of patient. That's the lens we are using.
But ma'am,
and working well.
Magnificent and hence they themselves, they call that they are advanced monofocal. They say don't call us EDOF.
So again, like I said, the definition is still not really solid and or put in paper, but what you need to understand is what do you get post surgery. You are wanting to give the patient a good distance, a good intermediate at around 50 to 60 centimeters distance, and the patient, if you combine it with monovision, will have a decent innate for near. So if you understand what the patient wants post surgery, you need not classify it even as an advanced monofocal or a EDOF. It's what the lens gives you. And this clinically, so we've compared 3 lenses that we did a study recently where we looked at IHANS, Magnificent as well as Vivity. And all 3 lenses, although few differences are there of course, all 3 lenses gave very good intermediate visual acuity. So a 0.3 logmar visual acuity at intermediate was seen in all these 3 lenses. So as long as you understand what the lens will give the patient, it doesn't matter what you define it as, but these 3 lenses work well.
So how about when we explain it to the patient that advanced monofocal, there is jumping of vision, there is no continuous range of vision, and there is no depth of
A
vision.
monofocal lens will never give
Advanced monofocal.
you. Which lens do you mean in particular?
IHANS and Magnificent.
There is no jump in vision. You will not just have a good near visual acuity because there are no different foci, right? It's a extended depth that they are getting. It's an extended focal length. So there will never be a jump.
So no difference between Ray 1 EMV or Magnificent, like it's all
There is a
same.
big difference in the way the
That's what-
optics are.
Can I just come in?
Yes, sir.
It's very simple. You said, what will you tell your patients?
Yes.
I mean, I have a very simple way of putting it. I tell him, if I put a monofocal, you will need to wear glasses always. You will have a reading aid of 2.5. If I put a trifocal, you can practically do away with the glasses because you can do your reading well without glasses. But with EDOF, your reading aid would definitely come down to 1.5. Now, if you go by that classification of EDOF, all these lenses more than classify into EDOF category because all these lenses, if you look at that defocus curve, it is convincingly broadened. Okay, some do better. When they do better, like let's say Vivity, when it does better, that means their chances of giving you a reading aid of 1 or sometimes in 0.75 is much more than for others. But unlike monofocal, all these EDOFs will definitely bring down your reading aid to around 1.5. Okay. Second thing, when you say in a setup where there are nothing and you still want to use, if you are convinced clinically that a patient has a healthy eye, his vision has good chances of improving, and you obviously don't see clinically anything wrong with the macula, EDOF is a better bet than going for a trifocal. Okay, because remember, EDOF would be a default lens, like how aspherics became the default lens compared to spherical lenses. Okay. Okay. Now, thank you so much, Tanvi.